Thanks for joining. Today we'll discuss about the emergencies asked in PLAB 1 exam. I'll also tell you how they frame the question and what are all the key important words that the examiner can twist your arm in the question. All right. Talking about the emergency medicine, first most important thing is the examiner can ask you about the chest pain. Remember, age is important in chest pain. If you think that the patient is young patient and the patient has got tenderness, on examination, it is costochondritis until otherwise proved. If the patient is a middle-aged gentleman, more than 55 years, male or female, with risk factors such as diabetes, hypertension, it is acute coronary syndrome. These are the two most important things the examiner can test you. The other variations of chest pain include patient who is recently traveled and has been affected with viral, has got a flu infection, usually viral thing, and then the examiner tells you that the patient is got chest pain which is worsening on taking deep breaths. That is pericarditis until otherwise proven. Remember, pericarditis can also present with heart failure. So the examiner can tell you that patient has got 2 weeks history of flu followed by swelling of the legs, raised JVP. You will have to think of viral myocarditis causing heart failure. Sometimes the examiner can also talk to you about acute coronary syndrome, which we discussed, that 55-year-old with hypertension diabetes is ACS until otherwise proved. In ACS, the examiner can tell you about two things. One is STEMI and another one is NSTEMI. Remember, the most definitive treatment they will ask you because they want a junior doctor to save patient's life. It is percutaneous coronary intervention. That is one thing you will have to remember. The same question, the examiner can tell you that the patient has got ACS diagnosed, treated, and then the patient has got a renal failure. Patient has been started on nitroprusside. So the examiner is talking about cyanide poisoning and wants you to give methylene blue as the treatment. So this is one thing you'll have to remember. The examiner can tell you about an alcoholic man who is vigorously vomiting, now presenting with chest pain. He's talking about esophageal rupture. And what is the first step in diagnosing esophageal rupture? It is a chest X-ray that we will have to do. When you do a chest X-ray, it is usually the left-sided pleural effusion. You see in an alcohol, you'll have to think of esophageal rupture, which is usually followed by vigorous vomiting. Sometimes the examiner can tell you that an alcoholic person is found on the roadside who is got NFA. What is NFA in NHS? It is no fixed abode. That is, he is homeless. Whenever a patient with history of alcohol injury, lying on the roadside, presenting with temperature, it is a lung abscess until otherwise proven. All right, these are the two most important questions the examiner can tell you about an alcoholic man. All right, tension pneumothorax, the examiner will ask you, or the examiner can tell you that the tension pneumothorax is usually sudden in onset. So the examiner will frame a question on a traumatic patient who is coming to the emergency department unable to breathe. You'll have to think of tension pneumothorax when the examiner mentions that the examination finding is a tracheal deviation. All right, needle insertion is the first most important management step or anything in tension pneumothorax. You will have to treat the patient in tension pneumothorax. These are the questions that the examiner can ask you. Please do remember, you'll read so much about chest pain and everything, but no one can tell you what questions and how questions are framed and what are the key important factors that you will have to look at in the question so that you can arrive to an answer. All right, we'll discuss more in the next slide. So if you're talking about chest pain, the first most important thing as a junior doctor is you will have to make sure that the patient life is not in danger. So you will have to send the investigations for the most important and most dangerous disorders. That is acute coronary syndrome, which is usually life-threatening. That is why troponin levels needs to be done, ECG levels needs to be taken, and chest X-ray needs to be taken. I'll also have to tell you that the chest X-ray findings are very important in patients who are basically diagnosed or who are basically coming to the emergency department. Why is that? Because chest X-ray is normal. The examiner can twist your arm by saying chest X-ray is normal, but the patient has got pleuritic chest pain, or the examiner can tell you that the patient has got chest pain when he is taking deep breaths in. That indicates that the patient has got pulmonary embolism on a background of OCP use oral contraceptive pill use, or obesity, or patient who has got other autoimmune disorders or malignancy. Chest X-ray is normal. Please do think of pulmonary embolism, and chest X-ray is not a definitive investigation for pulmonary embolism. All right. D-dimer can or cannot be given if the patient has got malignancy. So your next option is CT pulmonary angiogram. But if the patient is breathless and you've been given the vitals, you will have to treat the patient with enoxaparin. All right. Chest wall tenderness. One important question for PLAB is costochondritis until otherwise proven, and NSAIDs are the most important treatment that we will get. Talking about shortness of breath, first most important, children presenting with stridor, it is acute epiglottitis is one thing you will have to remember. But if the stridor is seen as sudden onset in the question, patient is usually seen well 30 minutes ago. Now patient presents with stridor. What do you think? It is the foreign body ingestion. I'll also tell you one more clue about foreign body ingestion is the examiner will tell you that there is focal wheezing. Imagine this is the lung and there is a foreign body which is usually on the right side. And then the lobe of the lung is occluded. This lobe of the lung usually produces wheezing. And on examination, you can find the wheeze only at certain location or certain position in the chest. That is called as focal wheezing. And focal wheezing in medicine is characteristic of foreign body ingestion in children. In adults, it is mucus plug. That's it. No more questions asked. Very simple and easy. Acute epiglottitis, hemophilus is the most important thing. You will find a lateral X-ray. Thumb sign is already seen on acute epiglottitis. If the patient has got shortness of breath and wheeze and nighttime cough, it is asthma until otherwise proven, usually in young adults or elderly children. If the patient is smoking, history of smoking, it is COPD. I'll also have to tell you that you have solved many questions in COPD, but the most outstanding question the examiner wants you to be alerted is patients with COPD do not develop clubbing. If patient has clubbing in COPD, that points towards underlying malignancy. This is what the examiner wants you to rule out. In COPD, it is the clubbing that usually gives you the malignancy. So the next most important step is you will have to do a CT thorax or CT thorax, abdomen and pelvis to rule out what malignancy, where is the position of the malignancy. This is one thing you will have to remember. All right. Heart failure, you all know for PLAB exam, it is the limb swelling, that is the lower limb edema, raised JVP, you will find heart failure. Pulmonary fibrosis, most favorite PLAB question is medications causing pulmonary fibrosis, asbestosis causing pulmonary fibrosis, silicosis causing primary fibrosis, pulmonary fibrosis. There is this famous question where the examiner tells you that a 73-year-old female patient who comes to the department or who comes to the outpatient department following 6-month history or 1-year history of gradual onset of shortness of breath. It is because the patient is using nitrofurantoin as a prophylactic agent for urinary tract infection. Now the patient develops pulmonary fibrosis. It is nitrofurantoin induced pulmonary fibrosis. That is why the examiner is interested in pulmonary fibrosis question. Copious amount of sputum that has been produced, repeated infections with cystic fibrosis, with foreign body occlusions. It is bronchiectasis until otherwise proven. Now, the examiner can also ask you about bronchiectasis complications because bronchiectasis is a chronic inflammation that's been going on. So many antibodies have been formed. Whenever there are plenty of antibodies that has been formed, you will have to understand that it causes amyloidosis. Whenever there is amyloidosis, it can lead to enlargement of the organs, that is the splenomegaly can happen, or nephrology, that is renomegaly can happen. That is kidneys are involved. So you'll find big kidneys in amyloidosis, which might be a complication of bronchiectasis. Very simple, very easy questions, just a bit of complications that's been adding in the recent PLAB examination. All right. Bronchiectasis, repeated multiple infections with the chronic cough, with the copious amount of sputum, that is characteristic of bronchiectasis. If the examiner tells you that there is a stony dullness on percussion on the left side, it is pleural effusion. Why did I say about left side? Because pleural effusion, the most common side is left side. But in heart failure, it is bilateral pleural effusion you will find. If the patient has got a abdominal trauma, say for example, young patient 25, bike driving, hit on the road, abdominal pain, blunt trauma, presenting after 2 days with difficulty breathing. You on a chest X-ray, you find that the patient has got left-sided pleural effusion with amylase raised. What is the first most important thing you will have to think of? It is trauma-related pancreatitis that can cause left-sided pleural effusion. This is what the examiner can ask you. All right. What is the first most important investigation if you find a patient with shortness of breath? The blood test is an arterial blood gas. ABG needs to be done. If it is an elderly with hypertension, diabetes, it is an ECG that you will have to select. If the patient has got a trauma and bloods have been given, it is the chest X-ray that needs to be given. Remember, if the patient has got a temperature, it is the blood culture that needs to be done. Very simple, easy rule in medicine. If there is temperature in the question, it is abscess until otherwise proven. It is infection until otherwise proven. No amount of autoimmune disorders can cause fever, especially for PLAB 1 question. So it is always the abscess, it is always the infection that the examiner can talk to you. I'll tell you about the abscess or the fever that is usually seen. What does the examiner wants to test you? The examiner wants you to understand that you are treating a patient in the emergency medicine, ruling out all the important causes. That is why an abscess question is asked in PLAB 1. I'll tell you what. Fever with chest pain, it is infective endocarditis. Fever with chest pain, it is pneumonia. Fever with abdominal pain, it is some splenic abscess. Fever with back pain, it is epidural abscess. It is abscess, abscess, and abscess that you will have to remember. That is why blood cultures needs to be done. All right. Patients usually have got this thing saying that the patient usually has got blood cultures when the examiner wants you to think of infection as the most important cause. Please do remember this. I'm repeating this question because you will find this question in your examination. All right. You all know about Glasgow coma scale. I only want you to understand that if it is 3, it is the deepest coma. It carries poor prognosis. What do you have to do if the patient has got a Glasgow coma of 3? You'll find the motor, verbal, eye opening and everything. You can find out the grades and everything, but this is not what I'm teaching you here. I'll tell you the most important points. If it is GCS of 3, it is the deep coma. Why is deep 3? Sorry, why is GCS 3 with deep coma important? Because that is when you will have to make sure that the patient needs to be in the ITU, not on the ward. You'll have to ring the registrar. If the patient has got a 3 to 8 GCS and the GCS has been dropped from 10 to 8 or 10 to 4 or anything, you'll have to ring the ITU registrar. Seek help is the first most important option you will consider. All right, but examiner wants you to be proactive before seeking help. So that is the option when the examiner wants you to tell that airway protection needs to be done in patients who have got decreased GCS or patient who is going into coma. This is one thing you will have to remember. Decorticate posturing and decerebrate posturing. If the patient has got a stroke above the midbrain nucleus, it is decorticate posturing. If it is decerebrate posturing, it is below the midbrain or brainstem. I'll also show you the images of decorticate position with elbows flexed and knees extended. Plantars are flexed. This is abducted and elbows are extended. That is decerebrate posturing. This is one thing you'll have to remember. I'll also have to tell you that chain stroke breathing is usually produced or usually seen in patients who have got brainstem decompression because brainstem has got respiratory centers that controls the respiration. We've got a brainstem, so I'll tell you what exactly the brainstem is like. All right. Please do remember this one. The picture you will need is, the picture you will need to remember for the exam is the brainstem. This is midbrain, this is pons, and this is medulla. All right. This is cerebral hemisphere. 1 and 2, it is usually the optic nerves are present, the cranial nerves are present in the cerebellum. Everything else is from the midbrain to brainstem. Remember this, it is the third nerve that comes here. It is the fourth nerve, that is the only nerve that is coming from the background. All right. Talking about the nerves in the, this is midbrain, this is pons, and this is medulla. All right. Third and fourth nerve are present in midbrain. Remember, third nerve is olfactory, optic, and oculomotor nerve. Third nerve is the oculomotor nerve. Usually, if pupils are involved, the lesion is in the midbrain. That's it. Chapter closed. Examiner will tell you that the patient has got a tumor. How do you know that the patient has got tumor? It is the change in the character of the headache. The change in the character of headache is usually from sharp to dull. This is what the examiner will tell you. The patient has been complaining of headache, which is usually got a change in the character of headache that causes a suspicion of tumor. Whenever there is tumor, it compresses the third nerve, and there is fixed dilated pupil, you'll have to think of that the lesion is in the midbrain. That's it. Talking about the pons, it is the fifth nerve, sixth nerve, seventh nerve that is present in the pons. All right. Talking about the midbrain, it is usually the 12th nerve, 11th nerve, 9th nerve, and 10th nerve that is usually present. 8th nerve is also present at the pons. All right, for PLAB 1. I'll tell you the most important thing. Any midbrain lesion will have this trigeminal. Remember, this is the side view of the brain. I'll tell you what are these. This is the cerebral hemisphere. This is the midbrain. This is the pons. This is medulla, spinal cord, and cerebellum. The most important lesion you will have to remember is the fifth nerve nucleus. Fifth nerve nucleus, trigeminal nucleus is usually present. The trigeminal nucleus is present usually at the junction of midbrain and at the junction of pons, and the fifth nerve nucleus extends into the cerebellum and also down up until the upper part of the spinal cord. So at any level of the brain, there will be fifth nerve involvement. So fifth nerve involvement is not usually the characteristic. That is why the examiner will tell you that patient has got fifth nerve involvement. Okay, but you must not consider fifth nerve involvement as a localizing point, because the fifth nerve can extend from top to bottom. So there is no point in considering fifth nerve lesion. So you'll have to consider third nerve lesion, fourth nerve lesion, 6, 7, 8, 9, 10, 11, and 12. If the patient has got 9, 10, 11, and 12 lesions that are involved, it is the medulla that is the localizing point. If the patient has got 5, 6, 7, and 8, it is the pons that is the site of the lesion. If the patient has got third and fourth nerve involvement, it is the midbrain that is involved. All right. Talking about the brainstem, back to brainstem, it is usually it usually contains the respiratory centers. So whenever there is brainstem stroke, it usually causes Cheyne-Stokes respiration. Cheyne-Stokes respiration, the examiner can give you a graph saying that the patient has got a normal respiration, showing this graph, and now the patient has got this graph, which is Cheyne-Stokes breathing. Usually the breathing gradually increases in depth followed by pauses. That is Cheyne-Stokes breathing. I'll also tell you one more graph. This is apneustic breathing, where there is prolonged inspiration and prolonged expiration followed by a minimal gap. That is apneustic breathing. This is also seen in brainstem lesions. All right. Next, we talk about the effect of different pupils. First most important effect for PLAB 1 is, I will have to tell you that if there is a unilateral pupil change, remember, it is always some lesion that is unilateral in the brain. If it is unilateral, if it is bilateral, it is systemic causes. What is systemic causes? Systemic causes is nothing but whole of the body has been involved by medications, drugs, and or some other things, metabolites or something else. If bilateral pupils are involved, this is how you'll have to differentiate a tumor, or if the patient is got a normal systemic inflammation or systemic causes. Why is this important? Because you are the one who is ringing the neurosurgery register saying that, doc, this patient needs dexamethasone because this patient has got a tumor on the CT scan. Why was the reason you've done a CT scan? What's the reason you've done a CT scan? It is basically because of the presence of unilateral pupillary dilation that triggered you to get the imaging of the brain. That is what you'll have to tell the examiner. So the examiner can classically frame a question on pupillary reaction. If the patient has got a pinpoint pupil bilaterally, it is opioid poisoning until otherwise proven. Opioid poisoning with respiratory rate depression, naloxone is the treatment. That's it, done. Third nerve pupil is usually fixed and dilated. All right. Midbrain pupil is very important. That is mid-size, but it will not be asked in the question. Why? Because it is very difficult for you to differentiate between the mid-size pupil and a normal pupil in the exam. So examiner will not be asking any of the questions. Even if it is a midbrain pupil involvement, the examiner will not talk about the pupil abnormalities because it raises a controversy. Very important. All right. Next, we talk about the pinpoint pupils. Two most important causes for PLAB. One is meiosis. It is opioids and pontine lesions. These are the two things. All right. Next, classic question. Again, examiner will tell you that the patient has got a normal disc. All right. If it is a normal disc, the examiner wants you to understand what is abnormal disc. This is abnormal disc. This is the patient who has basically got raised intracranial pressure. If there is raised intracranial pressure, there will be blurring of vision. Why is this blurring of vision happening? There is papilledema. Why is this papilledema happening? It is because of the raised intracranial pressure secondary to tumors. For PLAB 1, the most commonly asked question is tumors, tumors, and tumors. But I will tell you three most important scenarios where you will have to think of raised intracranial pressure. Could everyone please mute their mic? Thanks. So, talking about a young lady who is 19 years old, 20 years old, 21 years old, presenting with headache, papilledema, or headache, blurring of vision, nausea, vomiting, headache worsening on bending down is a raised intracranial pressure. You do a fundoscopy, please. The first most important step is fundoscopy. Even though any of the materials say it is imaging or stuff, if an young patient is presenting with headache and blurring of vision, it is fundoscopy that is the first investigation of choice. If you've got fundoscopy done, you will find that the patient has got papilledema. It is then the CT scan that needs to be done because we will have to rule out the systemic causes. It is intracranial hypertension that the examiner is talking about, and I want you to understand that a young patient or a young female patient who is coming to the department with headache, raised intracranial pressure to the emergency department, her vision needs to be saved. All right. The causes could be idiopathic intracranial hypertension secondary to obesity, secondary to pregnancy, secondary to OCP use, secondary to vitamin A use, or secondary to tetracyclines or doxycyclines that can be used for pimple treatment. Very important, easy. Acne treatment can be given. Most of the times, students will not answer this question, come back, rest, and then in the dreams they will realize, oh God, this is pseudotumor cerebri the examiner was talking about. So medications causes raised intracranial pressure that needs to be understood. Sometimes steroids can also cause raised intracranial pressure. If the patient has got headache that is characteristic of changing, the character of the headache is changed, it is tumor until otherwise proven. All right. What do you have to do? You'll have to do a lumbar puncture, make sure that the pressure is elevated. You will sometimes do a ventriculoperitoneal drain as well, which is the definitive treatment if the patient is not responding to medical treatment. What is the medical treatment? It is stopping the medications, reducing the weight, lifestyle changes, and then acetazolamide, then followed by the definitive treatment, that is ventriculoperitoneal shunting. All right. Next, we talk about shock. I will have to tell you that if you are thinking of shock in the examination, it is usually the blood pressure is less than 90. The systolic blood pressure is less than 90. This is one thing you will have to remember. Even without reading the question, if the systolic blood pressure is less than 90, it is shock until otherwise proven. What is the first most important step for shock? You will have to place two large bore IV cannulas just to make sure that the systolic blood pressure is coming more than 90. That is one thing you'll have to treat. Everything else is, you know, They are important, but the examiner is not concentrated on that. All right. There is something called septic shock. I'll tell you how to treat it and what to treat it. What's the most important question the examiner can ask you. So hypovolemic shock, the volume will be low because of the trauma, because of the bleeding, because of the internal hemorrhage. When I say internal hemorrhage, the examiner wants you to understand that whenever a patient is coming to the emergency department with cold, clammy hands and you are not able to see the bleed, where is the bleeding going on? It is the retroperitoneal bleeding. It is the abdominal rupture that is happening, which causes hypovolemic shock. That is one most important thing you will have to remember, please. In the question, if you are not able to see the bleeding anywhere, the gut is fine, back passage is fine, front passage is fine, there is no trauma, but the patient complains of low grade back pain with blood pressure that is dropped less than 90. It is the retroperitoneal bleeding that is happening. It is basically because of the rupture of the aorta that is usually tested for PLAB 1. Please to remember that it is the IV fluid with crystalloids of 1 to 1.5 liter bolus that needs to be given, please. Talking about hemorrhagic shock, if the patient is on anticoagulation, stop the anticoagulation is the first step, please. Most recently asked question, everyone was like what to answer, where to answer, didn't find the option. You will find it in the option C, option D, saying that please stop the medication apixaban, because there is no INR that is given, because for anticoagulation or oral anticoagulation we do not do INR. It is only for the warfarin we do INR. So hemorrhagic shock in a patient who is on apixaban, the apixaban needs to be stopped. First most important thing. Stop the bleeding, transfuse the patient very early. That's the one thing you will have to understand. All right. Can everyone see my screen? Can you say yes? Can you say no?
Yes.
And are you able to see the screen by management of shock?
Yes.
Great. Wonderful. So hemorrhagic shock, so we're talking about apixaban, warfarin, INR dose and everything else. Next, we talk about what is the first most step for the maintenance, for the control of hemorrhagic shock. It is the stopping the apixaban. Next, you will have to make sure, obviously, if there is shock, it is IV bore, cannulas and IV fluids. Next, consider tranexamic acid. All right. You know the protocol for the hemorrhagic shock, but I'll also have to tell you that the most important scenarios for hemorrhagic shock is patient who is alcoholic, patient who is got warfarin, patient who has got new medications, the new medication that has been started on warfarin, and now the patient has got multiple falls, did not tell the patient or did not tell the family, now presenting with confusion, tiredness, alertness, raised palpitations, raised heartbeat, you'll have to think of hemorrhagic shock. Obviously, you will see the hemorrhagic shock, you will possibly find a bleeding point somewhere, but please do make sure stopping the anticoagulation is the first most important thing. All right. Next, we talk about sepsis. Please do remember that if the patient has got a fever or hypothermia, most of the patients, students do miss this. High fever with hypothermia with the blood pressure less than 90 systolic blood pressure. This is a sepsis until otherwise proven. That's it. If they want to ask you about pathophysiology of sepsis, it is the nitrous oxide that is usually released from the blood vessels that causes vasodilation. That's the most important thing that is causing the low blood pressure. All right. The examiner can tell you about lactate. If the lactate is more than 2 millimoles per liter, it is sepsis until otherwise proven. All right. There has been a most important question recently saying that the patient has been confused, patient is lethargic, patient has got lactate of more than 6, but the blood pressure is normal. Patient was brought in by the ambulance, seen by a trespasser. You do not know the history. What is the first most important thing or the differential diagnosis you think of? It is seizure. It is not sepsis. If the patient has got lactate of more than 2 with normal blood pressure, normal temperature, It is seizure that needs to be understood. Most of the patients, most of the students do get confused in the examination hall, but I want you to understand that it is also a differential diagnosis for seizure with unwitnessed episode. Sepsis, obviously you'll find fever, hypothermia, fever or hypothermia with the low blood pressure, with lactate of more than 2 millimoles. It is sepsis until otherwise proven. First most important thing, when in doubt, treat sepsis. When in doubt, treat sepsis. You'll have to chant. When in doubt, treat sepsis. That's it. All right. Next, we talk about some of the, I'll tell you some of the classic questions that's been asked in UK exam, usually for MRCP and PLAB. All right. I'll tell you some classic scenarios. Patient is being recently diagnosed to have a chest infection. Now patient has got cough with green sputum. You'll be calculating curb 65 score, and the patient has got one curb 65, and then you've been given amoxicillin. Then you have given the patient amoxicillin, and then you have discharged the patient. What is the next thing the examiner wants you to understand? You'll have to follow up this patient, because this same patient is coming back to the emergency department with uncontrolled cough going on, with the temperatures going on. When you do a chest x-ray, there will be increase in the pneumonia or increase in the size of the patchy consolidation. What is the first thing you do? You'll have to check the blood pressure. If the blood pressure is less than 90, the patient has developed sepsis. This is one thing you'll have to remember. If this is not the scenario, the examiner can also give you another scenario mentioning that the 65-year-old gentleman with the background history of diabetes, hypertension, presenting with cough, green sputum, you've been given some antibiotics, and then discharge the patient home. Now this patient turns up to the emergency department, brought in by the daughter, because the daughter has noticed that the patient is not responding. What do you have to think? It is the sepsis that is basically causing the patient becoming drowsy, lethargic, fatigue, and tired. All right. First most important thing the examiner can give you in a hidden sepsis is his urine output being decreased. That's one important clue, please, because everyone knows what sepsis is, everyone knows what sepsis 6 is, everyone knows how to treat. It is only the diagnosis that you will have to make in your exam, please. All these are the bullet points that can give you the diagnosis in the exam. I'm telling you, listen to this class carefully. You will solve any question bank. All right. Next, what is the first most and best most important investigation? Obviously, everyone will send bloods, but I want you to understand that you will have to do a gas and a blood culture that needs to be sent. And please do start IV antibiotics after you take the blood cultures. That's one thing you will have to consider, please. All right. Next, we talk about major hemorrhage protocol. Major hemorrhage protocol is nothing but the examiner wants you to understand that you will have to put or insert 2 large bore cannulas and give crystalloids that's been going on. If the patient has got low blood pressure and is confirmed hemorrhage, it is the blood transfusion that needs to be given. All right. See, in this, you will find that recognize early and trigger the local major hemorrhage protocol as one thing the examiner can give you in the options. But before choosing this, as a junior doctor, imagine yourself in the settings of an emergency department and the patient is in front of you. What do? Do you activate the major hemorrhage protocol first or give the IV fluids? First, give the IV fluids and then you activate the major hemorrhage protocol, please. That's very important. You will have to understand the question. You'll have to understand where you are and then answer the question, please. All right. I'll also have to tell you that the transfusion early. Do not wait for lab results. The lab results are in pending is what the examiner will tell you, please. Please, first most important thing, wide bore IV cannulas, please. All right. Next, after you give wide bore IV cannulas, if there is no blood transfusion in massive hemorrhage protocol or massive hemorrhage that's been going on, please do select IV fluids. If there is blood transfusion, you will have to go and give RBC transfusion, please. All right. Tranexamic acid can be given. One most important question for PLAB 1, usually the examiners will concentrate on what are all the things that needs to be given. All right. The examiner will tell you that the patient has got an upper GI bleeding. Patient is alcohol. Patient has got a history of alcohol use. Patient has got varicose on endoscopy. Now the patient is presenting with hematemesis. You don't know what's going on. You find out that the patient has been having bleeding variceal hemorrhage as one most important query that's been running in your mind. What do? You give terlipressin, but the examiner is not happy, and the examiner wants you to know that if the terlipressin is working or not. What is the next most important question you ask the patient the next day? What rounds? Have you opened bowels? If you have not asked this question, the patient will tell you that, doctor, I don't know why. I've been going to the loo for at least 4 times today. What does it strike? What do you think? It is the side effect of terlipressin. If the patient has opened bowels next day after giving terlipressin, it means that the terlipressin started working. It means that the terlipressin is a vasoconstrictor which causes the vasoconstriction of the vessels that is supplying the gut. Because of the gut blood supply has been decreased, there will be hyperstimulation of the gut that results in diarrhea. So whenever you find that the patient has got terlipressin used and is complaining of diarrhea, the examiner will tell you what is the next best step. Do not do anything. All right, do not do anything until the patient has got fever. If the patient has got fever, yes, you will have to think of some Clostridium difficile or some fancy infections. But if the patient is given present and is waiting for this thing, you will have to just wait and watch. All right. Next, we talk about anaphylaxis. One most important question for anaphylaxis is patient is playing around a swimming pool. Patient mother has gone to the washroom to put the clothes in the washing machine, then came back. Patient is found to be confused. Patient is found to be drowsy. Patient has got fever. Patient is not wheezing. Patient has got focal wheezing. What do? It is the anaphylaxis that you will have to think. If the patient has got focal wheezing, it is the foreign body that is causing anaphylaxis. Very important, the examiner will tell you that the patient has got stridor, patient has got lip swelling, patient has got hoarse voice with tachycardia, hypotension, rash, angioedema. You'll have to think of anaphylaxis, please. First most important thing is drop the triggers for anaphylaxis. You will have to make sure that IM adrenaline needs to be given. Remember, before going or before transferring the patient to ITU, it is the 2 times of intramuscular adrenaline that needs to be given for the treatment of anaphylaxis, please. All right. The dose is 500 micrograms of 0.5 ml of 1 to 1000 intramuscular in the anterolateral thigh, and you will have to repeat it every 5 minutes if there is no improvement. Obviously, airway breathing circulation needs to be maintained. You all know that. All right. Next, we talk about the most important question. What do? If the patient has got a refractory treatment, what do? You'll have to make sure that the IV adrenaline infusion needs to be given, that is given in the ITU. So before calling the ITU, you will have to call critical care help. When do you call critical care help? It is after 2 doses of adrenaline that needs to be given. All right. Next, we talk about, when I talk about adrenaline anaphylaxis, I will have to tell you that whenever you do not understand what's going on, if it is in a short period of time, if it is in less than 15 minutes or less than 30 minutes, will be a bit gentle and will give some time. If it is less than 30 minutes, do not know the cause. It is anaphylaxis. Until otherwise proven, it is IM adrenaline that needs to be given. When I was working as a medical registrar, I did not know what happened to this 24-year-old chap who's come directly to the A&E from the pub saying that he can't speak. I don't know why he can't speak. He's not able to give me any answers. He's not got any rash. I just have given him IM this thing, and I asked him what happened. He just mentioned he's eaten this fried squid or something, and then he developed anaphylaxis. This is one thing you'll have to remember, please. So it is a safe doctor that you need to be, not a smart doctor. Please make sure that you protect the patient's life at any cost. All right. Next, we talk about hypertensive emergency versus urgency. One thing I want you to tell is, in hypertensive emergency, there is E, and it starts with E, and in urgency, it starts with U. So E is for end organ damage. That's it. You're done with hypertensive emergency and urgency. You will remember this for life. Hypertensive emergency, there is raised blood pressure with end organ damage. What is end organ damage? It is the kidney damage, liver damage, spleen damage, eye damage, heart damage, any damage. And how do you see that the organ is damaged? Because the organ specific bloods are raised. What do you mean by organ specific bloods? Say for example, if renal is injured, there will be rise in creatinine. If liver is injured, there will be rise in ALP or ALT. That is one thing you will have to remember for end organ damage. If there is heart that is involved, it is usually the troponin that is raised. ECG findings you will be seen. If the eye is involved, it is the blurring of vision that is usually caused. It is loss of visual field defects that is usually seen in hypertensive emergency. So from now for lifetime, you'll have to remember that whenever there is hypertensive emergency, it is the end organ damage that is involved. If it is urgency, there is no end organ damage that is involved, but the patient needs to be treated urgently in order to prevent the end organ damage. That is one thing the examiner can ask you. I'll tell you more about in the revision course about how to diagnose an organ specific problem, how to come to the diagnosis depending on the clinical signs and symptoms. Very easy to remember, very elaborative. You'll get the gist of PLAB 1 exam. All right. Next, we talk about the management on the principles of the treatment of hypertension. The examiner wants you to understand that you will have to reduce the blood pressure by 10 to 25%. First most important thing, do not do it suddenly. You will have to go gradually by 10 to 25%. All right. What is one most important condition where you will have to treat aggressively with antihypertensive medications? What is the one medical condition that you will have to treat? It is the aortic dissection that needs to be given, and in the examination, the examiner will tell you that the femoral pulses are weak, or the radial delay, or there is a difference in the blood pressure of more than 20 systolic blood pressure. This is one thing you have to remember for aortic dissection. All right. Management, it is the labetalol IV that needs to be given. NHS loves IV labetalol. So please do make sure that the treatment is IV labetalol. If the patient is not, if you've not got any of the IV access, if it is difficult finding veins, it is nifedipine that needs to be given, please. All right. Sometimes the target blood pressure can also be asked. For aortic dissection, it is the systolic blood pressure of 120, and for preeclampsia and eclampsia, it is the less than 160 or 150 can also be used for preeclampsia and eclampsia. All right. If it is a stroke, if it is ischemic stroke, you'll have to lower only if the patient has got more than 220 by 120. This is a new guideline. Please do stick to the guidelines. All right. If it is the hemorrhagic blood pressure, the most important thing is the systolic blood pressure needs to be come down by 130 to 180. I'll tell you one interesting fact. Most of the patients on the stroke ward do have raised blood pressure. Is raised blood pressure good or bad? It is good. Why is it good? If the raised blood pressure is good, because the carotid stenosis, it is the increased blood pressure that the patient needs to have in order to pump adequate amount of blood to the brain. This is one thing you will have to remember. That is why the nurses on the stroke ward are concerned. Doctor, what to do? This patient has got a blood pressure of 170 by 90 or 175 by 90. What's the next most important question? Even though this question might not be asked in PLAB 1, I would say, has the carotid stenosis been ruled out? Has a carotid Doppler been done for this patient? Why? If the patient has got a significant stenosis of more than 90, it is usually the high blood pressure that I need to make sure that the brain is being perfused well. That is one thing I will have to remember. Can you see this? In the special cases, there is this investigation called MAHA, microangiopathic hemolytic anemia. You will have to do peripheral smear, and on the peripheral smear, the examiner can tell you that there are schistocytes. Think of hemolytic anemia that's been going on. All right. Next, we talk about STEMI. Whenever there is ST segment elevation that is raised on the ECG, it is STEMI. One most important thing you will have to remember is do not delay the treatment. It is basically percutaneous intervention that needs to be done. Most classic question you will be asked is, patient has got changes in lead 2, 3 and AVF. Lead 2, 3 and AVF. This is the right coronary artery that the examiner is worried about. Inferior myocardial infarction. Why is inferior myocardial infarction for PLAB exam or UK exam? Because inferior myocardial infarction is very difficult to distinguish between pulmonary embolism and inferior myocardial MI. That is why inferior myocardial infarction is usually asked in the question. The examiners are trying to prepare you for the next level of exam, with PLAB 1 being asked for inferior myocardial infarction, because inferior myocardial infarction, when you give when you give nitroprusside, when you give nitrates, there will be vasodilation, there will be inadequate filling of the inferior vena cava, and there can be risk of hypotension. That is why in patients who have got hypotension, especially in inferior myocardial infarction or right-sided myocardial infarction, you will have to prevent giving nitrates. Only give nitrates only if the patient is not hypotensive. This is one classic thing you'll find in every textbook. All right. Next, we talk about the immediate medical treatment that is usually asked. It is the aspirin 300 milligrams and prasugrel 60 milligrams or ticagrelor 60 milligrams. That is one thing you'll have to remember. If it is the pain relief, it is morphine and oxygen only if SpO2 is less than 90. This is an MRCP part 1 question. You need not remember this, but please do remember aspirin and prasugrel needs to be given. I have specifically put prasugrel, ticagrelor, not clopidogrel, because there are studies where clopidogrel interacts with other medications such as pantoprazole. Given that the P2 Y12 inhibitor is being discarded in NHS, it is the prasugrel, ticagrelor, aspirin that needs to be given. Oxygen needs to be given only if the patient has got SpO2 of less than 90. All right. Next, we talk about the reperfusion strategy if the patient has got ST segment elevation. I will have to tell you that primary cutaneous intervention or percutaneous coronary intervention is the most important treatment for ST segment elevation. If I was a PLAB 1 student, I would take the note of this thing. These are the two most important things the examiner wants to ask you. Everything else is MRCP part 1 and part 2. All right. Reperfusion options, primary percutaneous intervention. It is offered to all within 12 hours of onset of symptoms. You will have to make sure that the tertiary center transfer needs to be done if the patient has got ST segment elevation. All right. Additional things, anticoagulation, fondaparinux needs to be given if the patient has not got any percutaneous coronary intervention that's being done. All right. One most important thing I will remember is if you've got hypotension, avoid nitrates is the rule, please. All right. There is this crazy question where the examiner wants you to understand that the patient has got a chest pain with history of diabetes, hypertension, cigarette smoking, or family history of coronary artery disease, now presenting with shortness of breath. When you do a chest x-ray, you'll find bilateral pleural effusions. What is the first most important thing you do? You'll have to think that the patient is presenting with acute heart failure. Examiners might not ask you, but examiners want you to know that the acute heart failure presentation is bilateral pleural effusion, where you will have to treat this patient with the diuretics as the first most important step, because shortness of breath needs to be relieved. It is the aspirin, ticagrelor, prasugrel, percutaneous coronary intervention definitive, but diuretics needs to be given in patient who is presenting with acute heart failure with bilateral pleural effusions. Then we talk about NSTEMI. If there is NSTEMI, I want you to understand that there is no ST segment elevation that is usually seen on the ECG. What is the treatment that you will have to do? You will have to make sure that oxygen needs to be given, morphine needs to be given, nitrates needs to be given, and aspirin needs to be given. All right. Again, it is the aspirin, it is the ticagrelor or clopidogrel, but I will also have to go with the prasugrel, please. All right. Next we talk about gray score. I'm not worried about gray score for PLAB 1, please. All right. There is this famous question called, what do you do if the patient has got high risk of heart disorders? You will have to please make sure that the coronary angiogram needs to be done. Why does coronary angiogram needs to be done? Because it acts both as diagnostic and also therapeutic. You can find out how much of vessels are occluded, and you can also put the stent directly in. Examiner will tell you that the patient has got a primary coronary intervention that's been done, and now the patient's ECG shows continuous electric monitoring. I'll show you all the ECGs in the revision class as well. ECGs, what is the first step you do? You will have to make sure that the patient needs to be treated for the life-threatening arrhythmia that's been going on, because patient who is presenting to the emergency department with the heart problems, the most important step is you'll have to make sure that the arrhythmia needs to be prevented, because out of hospital cardiac death is ventricular fibrillation in most of the patients. All right. Next, we talk about pulmonary edema. One classic question for PLAB 2 is patients with renal artery stenosis. How do they present? It is hypertension, not resolving to any of the antihypertensives. Now the patient has got hypertension that's been going on with flash pulmonary edema that is suggestive of renal artery stenosis. That's one thing you will have to remember. The examiner can give you some clues saying that the patient with renal artery stenosis has been given ramipril, but what happened? There has been worsening creatinine level that indicates that the patient has got renal artery stenosis. That is why the creatinine has been raised. Remember, for PLAB 1, it is the flash pulmonary edema that the examiner can ask you in order to diagnose the patient. All right. Everything else is easy. Everything else is the same. Pulmonary edema, mitral stenosis patients presents with pulmonary edema. Left heart failure patients can present with pulmonary edema. All right. If the patient has got mitral stenosis, the examiner will tell you that the patient has got mid-diastolic murmur on the left lateral position is one thing you will have to remember. Whenever there is pulmonary edema, remember for the lungs, there will be pulmonary edema, there will be lot of fluid, and there will be congestion on the chest X-ray if you do an X-ray. All right. The examiner wants you to understand that the signs and symptoms for pulmonary edema is usually shortness of breath, difficulty breathing, coughing with pink frothy sputum. That is characteristic of pulmonary edema. Why am I talking about pulmonary edema with whiteout shadows on a chest X-ray in pulmonary edema patients? Because the examiner wants you to understand that a trauma patient who is presenting to the emergency department after shortness of breath, when you do a chest X-ray, there will be pulmonary contusion in trauma patient, which is usually unilateral, not restricted to the borders. That is one thing you will have to remember. Whenever there is trauma, there will be pulmonary contusion, usually not limited by the borders. The pulmonary contusion can be crossing the borders. This is one thing you'll have to remember. So please do remember the differentiation between pulmonary edema and pulmonary contusion. There will be trauma patient presenting to the A&E with chest pain. Usually there will be whiteout lung, unilateral side. Most of the patients do think that it could be mucus blur, something else. But if it is crossing the border, if it is irregular, it is pulmonary contusion. If it is pulmonary edema, it is bilateral, it is whiteout lung, it is not obeying the borders as well, but it is bilateral with involvement of heart. All right. Everything else is easy. I want you to understand for pulmonary edema, it is ABC, and then you will have to give diuretics. It is the furosemide that needs to be given. All right. Next, we talk about the worsening pulmonary edema. You have given diuretics, you have done the management. The examiner will ask you, what will you do next? You just give him non-invasive ventilation, please. That's one thing you will have to do, please. All right. So you will have to speak to the ITU, make sure that the patient has been told regarding the non-invasive ventilation, and then you will understand that the examiner is interested about another question called what is the next best step you do if the patient is considered for a non-invasive ventilation. And in the third or fourth option, you will find evaluation of arterial blood gas. Yes, repeat blood gas needs to be done if the patient has been having non-invasive ventilation. All right. Next, we talk about pulmonary edema. If the patient has got pulmonary edema and if the patient is complaining that the patient has got decreased blood pressure, what do? You just make sure that the patient has been ruled out of having an acute coronary syndrome. That is one most important thing you will have to understand. All right. ACS causing pulmonary edema is very rare, and you do understand that the patient who has got history of diabetes, hypertension, smoking, history of family history of heart disorders, it is basically the systolic blood pressure that needs to be given. Sorry, it is basically the systolic blood pressure less than 90, that is the presenting feature, please. All right. Cardiogenic cause, one most important thing, it is the myocardial infarction that you need to rule out in a elderly patient. When I say elderly, it is more than 55, although 55 are very young, but 55 with history of diabetes, hypertension, smoking, family history of heart disease with raised cholesterol or something like that. It is coronary artery disease that usually causes cardiogenic shock. Now here comes the famous question when I discussed this at the start of this lecture. It is the patient presenting with flu or with history of flu, now presenting with cardiogenic shock. It is usually viral myocarditis with raised CK, with raised troponin that has been having. Please to remember that viral myocarditis is the most classic important, commonly asked, whatever adjectives you want, you use it, but it is presenting in young patients with history of flu, with heart failure, acute heart failure. Myocarditis is the cause. All right. Next, cardiogenic shock. It's very easy. You'll have to treat the cardiogenic shock. All right. Next, we talk about the broad complex tachycardias. I'll show you the ECGs in the revision lecture. Narrow complex tachycardias. Asthma, we'll talk about it. Next, we'll talk about pneumothorax. Okay. You'll have to chant this. Tall, thin, young male smoker. That's it. Tall, thin, young male smoker presenting with shortness of breath after a flight journey is tall, thin, young male smoker presenting with shortness of breath after a flight journey is primary spontaneous pneumothorax. Most of them argue that the patient has got pulmonary embolism, but if the patient has got pulmonary embolism, there will be pleuritic chest pain. That is usually the chest pain which is worsening when taking deep breaths in. That is usually the cause for pulmonary embolism or suggestive of pulmonary embolism. But if it is a tall, thin, young male smoker, whatever is he doing, and is now presenting with shortness of breath, I will want to rule out the primary spontaneous pneumothorax. If the patient has got an underlying COPD, asthma, chest infection, pneumonia, pulmonary fibrosis, I will have to consider this as a secondary pneumothorax, please. If the patient is presenting to the A&E with the trauma, it is the traumatic or tension pneumothorax that I will have to rule out, please. One most important thing is the sudden dyspnea that needs to be treated, that needs to be considered in patients with pulmonary pneumothorax. All right. Next, we talk about tension pneumothorax. This is a life-threatening condition. Please do not wait for a chest X-ray. You will have to do a clinical examination where there is hyperresonant on the side of the tension pneumothorax with the deviation of trachea. This is one thing that is suggestive of tension pneumothorax. Please do not wait for anything. Insert a large bore cannula into the second intercostal space. That's one thing you will have to do, please. Examiner can ask you about the definitive treatment. Sometimes if it is a definitive treatment, it is chest drain, please. If it is the initial treatment, it is a large bore cannula that needs to be done, please. All right. Next, we talk about pneumonia. We already discussed about the curve score. It is confusion, urea, respiratory rate, blood pressure of less than 90, age of more than 65. Blood pressure of less than 90, you'll have to think of sepsis secondary to infection. That's one thing. All right. Next, we talk about management of pneumonia. All right. You'll have to make sure that amoxicillin clarithromycin needs to be given as per the curve criteria. I'll talk to you about the different types of pneumonias in different, what are all the antibiotics that needs to be used in pregnancy, children, adult, immunocompromised. If the patient is alcoholic, what are all the antibiotics that needs to be given? I will talk to you about that. All right. Next, we talk about life-threatening hemoptysis. Again, if it is life-threatening hemoptysis, first most important thing is you will have to make sure that the patient's blood pressure is not falling. That's one thing you will have to think of. All right. Whenever there is hemoptysis, if it is a young patient, the trauma is one most important. If it is a child, obstructed foreign body is one most important. If it is an elderly patient with the weight loss history of smoking, it is tumor. If the patient is traveling to tropical countries, India, Africa, Pakistan, it is tuberculosis. If the patient has got a family history and if the patient has got bleeding mucosal ulcers, I will have to think of arteriovenous malformations. And most of the examiners do not ask about all these things, but they are interested about the vasculitis because young female patients who is presenting with joint pains, rash, systemic involvement, it is vasculitis that needs to be given, that needs to be understood. Usually the examiner can tell you that the patient has got hemoptysis and hematuria. It is Goodpasture syndrome until otherwise proven. That's it. Most of the patients are female patients. All right. Next, we talk about pulmonary embolism. One most important thing, if you talk about pulmonary embolism, the treatment for pulmonary embolism is Clexane. But the NICE has recently updated its guidelines saying that you can also use apixaban. If you want, you can Google this after the revision lecture. The use of DOAC, that is direct oral anticoagulation, in the treatment of pulmonary embolism is apixaban. You'll have to give the patient 1 week of apixaban with the 10 milligrams in the morning and 10 milligrams in the evening, followed by 5 milligrams to be followed until seen in the DVT clinic. All right. So if you do not find the option of subcutaneous heparin, you will have to go for apixaban. I'm not talking about pulmonary embolism because you all know that the patient who is obese, not trapped, not walking, not exercising, increased weight, history of malignancy, history of cancer, history of OCP use, now developing chest pain, shortness of breath, not able to speak, not able to breathe. The respiratory rate is high. ECG shows sinus tachycardia, which is a common characteristic normal finding on the ECG, and the characteristic finding on the ECG is S1Q3T3. What is the next best step in the treatment? It is basically the heparin or enoxaparin that needs to be given, but I want you to remember the updated guidelines of treating with apixaban as well. All right. If the patient has got hemodynamically unstable pulmonary embolism, you will have to thrombolyze this patient, please. All right. Next, we talk about, can you see this? Immediately, it is low molecular weight or DOAC. All right. If it is a long-term anticoagulation, if you find the cause, it is 3 months. If you look for the underlying cause, it is 6 months. All right. Next, we talk about the upper GI bleeding. Whenever there is upper GI bleeding, I want you to understand, if it is a young patient who is alcohol smoker now presenting with this thing, it is the peptic ulcer disease that needs to be treated. All right. For your PLAB 1 examination, if you are thinking of most of the things, it is the gastric ulcer and the duodenal ulcer. What is this? Why is gastric ulcer important and duodenal ulcer important? What is the role for differentiation between these two? Because gastric ulcer gets cancer. The duodenal ulcer do not get cancer. Which treatment are you worried about? If the patient has got a peptic ulcer and it is a gastric ulcer, gastric peptic ulcer, patient gets gastric cancer. So surveillance is important for this patient. If the patient has got a peptic ulcer disease and if the patient has got a duodenal peptic ulcer disease, which do not get cancer, there is no need for surveillance or the follow-up endoscopy that needs to be given. All right. The examiner will tell you that the patient is eating peptic ulcer, spicy foods. Patient has got H. pylori infection. Patient has got H. pylori infection. And now the patient is usually presenting with abdominal pain. You'll have to think of peptic ulcer disease. Gastroduodenal erosions. I also want to understand that patient who has got an FA, that is no fixed abode, is presenting with longitudinal ulcers. Patient is presenting with history of multiple sexual contacts. Patient has got herpes. Patient has got cytomegalovirus. Patient has got HIV. I will be worried about something because patient who has got gastroduodenal erosions might be having esophageal ulcers. Whenever there is ulcer, I will have to differentiate that patient who has got linear ulcers and circular ulcers, because the examiner wants you to understand that herpes usually causes circular ulcers in the esophagus and CMV usually causes linear ulcers. If it is a Mallory state, the examiner will be talking about an alcohol who has got vigorous vomiting. If it is Boerhaave syndrome, the patient will be having pneumothorax or air in the mediastinum because of the complete rupture of the esophagus. That is one thing I am worried about. All right. We discussed about viruses and everything else. All right. First most important thing, resuscitation. Two large bore IV cannulas, IV fluids. If IV fluids are not available, if bloods are not available, then go for IV fluids, please. All right. In the question, you can actually clearly see what it is. All right. Obviously, stop all the anticoagulants, antiplatelets. terlipressin. And what is the side effect of terlipressin? You're all masters now. It's the diarrhea that needs to be given. All right, definitive control and follow up. If it is gastric ulcer, it is definitive follow up. If it is duodenal ulcer, it is depending on the consultant if you want to follow up or not. That should not be a problem. All right, next we'll talk about the meningitis and sepsis. If the patient is young patient, if the patient is 21-year-old, moving out of the house, staying in dormitory, staying in hostels, and is avid pub user, pub goer, drinks a lot of alcohol, plenty of friends outside, you'll have to think meningitis. If the patient is presenting with headache, fever, neck pain, neck stiffness, that's one most important thing, please. Meningococcal meningitis is the most important infection that needs to be considered, please. The examiner knows that you are reading meningitis anyway, but some classic clues I'll tell you. I'll not touch on everything, but I'll tell you some classic clues. If it is rash, it is meningococcal. If it is rash with sepsis with adrenal hemorrhage, it is meningococcal septicemia, please. If you think that the patient has got tachycardia and blood pressure drop, that is meningitic sepsis, please. Sepsis secondary to meningitis. All right. One most important thing, usually the examiners will talk about small children. Patient has got meningitis. Patient has got treated with meningitis. Children, what is the next most important thing you will have to do? It is the hearing assessment. It is follow-up for hearing assessment. This is the most important question, please. Even for PLAB 2, you will have to explain in the course that the patient has got meningitis. We will treat the meningitis. Do not worry, there is treatment. But the most important thing is patients needs to be followed up. The children needs to be followed up for the hearing assessment, because patients with background of meningitis usually have got unilateral hearing loss. That's one most important thing, please. All right, antibiotics needs to be given. What is the first most important antibiotics that is given? It is ceftriaxone, because ceftriaxone can also be used in pregnancy. Very important and very easy. All right. Can you see this? Dexamethasone needs to be given if the patient has got a pneumococcal meningitis. What did we just discuss about this thing? Dexamethasone 10 milligrams IV needs to be given if the patient has got pneumococcal meningitis, because children are usually affected with pneumococcal meningitis, and the complication for children with meningitis infected with the pneumococcal is hearing loss. So hearing assessment needs to be done. All right. The examiner wants you to understand what is the next best investigation. It is a lumbar puncture. All right. If you are suspecting meningitis, please give antibiotics first. Do not do the lumbar puncture. All right. Always check for papilledema or do a fundoscopy at the bedside if the patient has got papilledema or not, because if there is papilledema, it is usually indicative of raised intracranial pressure, and this raised intracranial pressure is usually a contraindication for lumbar puncture. All right. Next, we talk about some CSF analysis. I will tell you if the patient has got hemorrhagic stat CSF with meningitis, it is herpes meningitis until otherwise proven. That's it. This is one most important thing you will have to remember. If it is increased RBC in the lumbar puncture, it is herpes infection that needs to be considered. All right. Obviously, bacterial infection, the bacteria eat away all the glucose. So glucose is low. The bacteria turns this glucose into the protein. So protein is high. What is the cell of acute inflammation? It is the neutrophil. So if it is an active inflammation, if it is an acute inflammation, it is the neutrophil that increases. All right. If it is a viral infection or if it is a chronic infection, the cell of chronic inflammation increases. What is the cell of chronic inflammation? It is lymphocytes that increase. So chronic infection, chronic meningitis, it is the lymphocytes that increase. All right. Viral meningitis is an acute infection, but there will be infection that has been going on long time. So neutrophils are faded off by the time the patient develops symptoms. That is why the predominant cell in viral meningitis is lymphocytes and predominant cell in bacterial is neutrophils. virus do not are not able to consume glucose. So protein is usually normal. They cannot produce protein. All right. This is one thing you will have to remember, please. What is the most important thing? Public health needs to be identified. Isolate the patient and inform the public health immediately. Recently asked question is prophylaxis of meningitis. What do you need to do? It is a ciprofloxacin that needs to be considered. Sometimes it is a rifampicin that can also be used. All right. Encephalitis. If the patient has got seizures, if the patient is confused, if the patient is not got normal consciousness, why? Because the seat of consciousness is the cerebral cortex. If the cerebral cortex is involved, the patient becomes lazy, patient becomes drowsy, patient becomes muddled, patient doesn't able to speak, patient has got seizures. If you've got all these features with raised temperature, it is encephalitis. All right. I'll tell you one simple thing. If the patient is a young patient who is suddenly brought in to the emergency with the change in behavior, please do think of NMDA encephalitis. That's it. This is the question that is asked, and you will not know what question the examiner will be asking. Why is this guy who is coming to the emergency department has got change in behavior? Possibly it could be related to the drug use, but the patient has got a very good record, the studying very well, not gone outside. All these clues will be present, but still he's got some behavioral change. Then you will have to think of NMDA encephalitis. This is what personality change is one important thing you'll have to identify. And the examiner sometimes can ask you a 60-year-old female patient presenting with change in behavior. It's got some bit of weight loss, but there is abdominal swelling. What do you think of? It is the ovarian cancer that is causing encephalitis. Autoimmune encephalitis could be the cause of the change in personality disorder with encephalitis in 60-year-old female patient. What is the swelling she's got? She's got some ovarian malignancy, because encephalitis is usually associated with ovarian tumors. That is why people do CT of the thorax, abdomen, and pelvis. I understand this is not your level. You think that this is not your level, but when you sit in the examination hall, the examiner will ask you this, because the examiner doesn't want you to answer this question. It is only up to 60% of the questions that you will be able to answer, and the rest of the 60% are all the follow-up questions that you will see. All right. When you attend the revision course, you will understand, get the map of everything, what to answer, where to answer, when to think of, what clues to be done, what to be ruled out. All right. So next most, see this anti-NMDA receptor is one most important antibody that you will have to send, because that presents with change in behavior. Everything else, herpes simplex virus treatment of acyclovir, treated with acyclovir, patient presenting with change in behavior, with the neck pain, neck stiffness, seizures. Patient is usually brought in by the wife, by the family, by the daughter, by the brother, mother, and everything. Patient does not usually come on their own. Viral encephalitis, herpes simplex encephalitis, the MRI shows that there is a predisposition for the temporal lobe involvement. That is one thing you will have to remember. And what did we discuss previously? If the patient is presenting with acute behavioral change, it is NMDA receptor encephalitis, and there will not be any characteristic temporal lobe changes, please. All right. Next, we talk about the treatment of herpes encephalitis. Per your level, it is herpes encephalitis that is usually the acyclovir that is involved. All right. Whenever there is acyclovir that is involved, the examiner wants you to understand for how long do you continue the acyclovir is the most important question. It is for 2 weeks. And the examiner can also give you an option of ganciclovir. Why is ganciclovir involved? It is the treatment of CMV. Why is it important? Why is acyclovir and ganciclovir needs to be known by a junior doctor? Because acyclovir is usually metabolized by thymidine kinase, and ganciclovir is also by a kinase. But the problem is there can be easy development of resistance to acyclovir in CMV. That is why CMV patients do not use acyclovir, it is rather the ganciclovir that we use. Herpes encephalitis, it is the treatment of herpes encephalitis with acyclovir for 2 weeks is the clue. If the patient has got an MRI that is characteristic of temporal lobe involvement, if there is no temporal lobe involvement changes, it is usually the anti-NMDA receptors that are involved. All right. Thank you very much for attending. I'll see you again in the revision course. Thanks. If you've got any doubts, please text in the group. I'll be there for the next 15 minutes. Thank you very much for attending. Great to see you all. Bye-bye.